Hi guys, welcome back to the MRCP PACES series. This is another video, and today it's going to be a very special one because we are doing neurology. Yes, it is something that is feared all over the place. It was feared by me, it was feared by all of my friends, it was feared by everyone I knew. Okay, so today I'm going to cover neurology, but not quite in the traditional sense. So stay with me until the end so that you get the overall idea that I really want to drive home and deliver to you today. So this presentation is titled Neurology Exam, the Big Fuss. All right, and we all know what the big fuss is. I'm going to get to it in a minute. But for those of you who don't know me, my name is Dr. Vishal Kumar. I am a doctor in the UK. Feel free to check out my channel to learn more about me or from my website, which is keenmedic.com. Let's get started. So, neurology strikes fear in everyone's hearts, right? But let's think about it. Going by the Keen Medic ethos, you need to work smart, right? So let's be smart about this. So why is it feared? One, the difficulty in eliciting the signs, or the rare conditions and syndromes that can come up in PACES. Come on now, how many of us have really seen Charcot-Marie tooth? Or even myotonic dystrophy. I'm talking about common things, right? We see aortic stenosis or bronchiectasis far more commonly than things like Charcot-Marie tooth or myotonic dystrophy. I'm not sure how many of you, at least within the UK, are out there who have seen more of these rare neurological conditions than the others that I just described. Or is it the difficulty in understanding the signs that you do elicit? Because sometimes you can elicit the signs, but even then you can't make head or tail of it, and you kind of just say it out, and you just kind of stand there hoping that, oh yes, you're going to get the points, but it doesn't quite work that way, does it? Or is it the fact that there are many places that there could be an issue in the neural network, in the long and complex neural networks, starting from all the way in the brain to the very tips of our fingers and toes, right? So there can be issues anywhere, literally. Whereas with, say, the heart, you know that there is only one issue, and it's very much localized to the heart, right? Or with the respiratory system, it's again similar. You know that the problem is within the lungs. There is no other problem anywhere else. It's one system and it is in one place. Whereas with the neurological network, it is literally all over the entire body. So it makes things a little bit more complex. So I can understand, and I had all of these issues. Okay, I personally did have all of these issues, and I know that a lot of you will as well. And that is why this video exists, guys, so that we can try and look at these factors. But bear in mind, not all of them are going to be ones that we can change around immediately. Okay, there is one which I'll get to in a second. So the first three, the difficulty in eliciting signs, the rare conditions and syndromes, and the difficulty in understanding the signs that I elicited, I've got bad news, guys. So, unfortunately, there is no other way but to practice and practice and practice and practice hard and to increase your exposure. So go to those neurology wards and ask your friends to tell you if you have any, if they have any patients. Ask your registrars and consultants, and expand your network so that you have that level of exposure. Go to face-to-face courses as well, and learn the patterns. So with neurology, the key thing is learning the patterns. Okay, it's all about pattern recognition. And that's what I mean here by patterns and associations of each syndrome. So, for example, let's take myotonic dystrophy. Okay, so the pattern would be that there would be a patient as you go in, right, and they will usually be they will have some kind of frontal balding, right? They may have insulin pens and insulin glucose check marks on their fingers, suggestive of diabetes. And when you shake their hands, which is what often people say you should do, when you shake their hands, what happens is that you notice the myotonia in the hands. Okay, um, these kind of things. So this is the typical picture, and this is the pattern that you need to recognize. But this doesn't come without exposure and experience. You know, even though you may be able to learn the patterns, if you haven't seen this patient, or at least once or twice in your life, you won't be able to recognize it. It's extremely hard to recognize these things without having some exposure first, and that is why it is so key. And as I said, for these three factors, there is absolutely no other substitute other than to learn, practice, get the experience, and go do it. Okay. However, for the last one, which was the fact that there are many places around the body and that it's really long and complex, this actually doesn't have to be such a big issue. Now, it is now time to transform your thinking about this. In terms of PACES, okay, you don't have to be neurologists, right? You just keep in mind what you're trying to do. What you're trying to achieve with PACES is the level of a UK medical registrar, right? So you don't have to be able to pinpoint exactly what the issue is and where it is. And this is something that even trained neurologists struggled with. Okay, I have seen very experienced neurologists provide opinion on patients with neurological conditions and have differing opinions. And this is commonplace. You find this often. However, this is what you need to be able to do. You need to be able to swiftly examine and do it convincingly. By convincingly, what I mean is that you need to be able to show that this is not the first time you're doing neurological examination, okay? Whether that's cranial nerves, upper limbs, lower limbs, gait, whatever that may be. You need to do it swiftly, convincingly, and comprehensively. You need to be able to pick up the signs and piece them together, all right? So the signs will come, whether that's increased reflexes, cogwheel rigidity, weakness, you will pick them up, but it's no good just finding them. You need to get them together. And then after getting them together, you need to form an overall picture, okay? And after forming the overall picture, you need to figure out where the lesion might be, because the overall picture will guide you as to where the lesion could be, okay? Is it the upper or lower motor neuron? Is it unilateral or bilateral? And which part of the lower or upper motor neuron is it? So that's LMN is lower motor neuron, UMN is upper motor neuron. By which part, which bit, what I mean, for example, is, with lower motor neuron, it starts off at the level of the spinal cord, right? So it's fairly long if you think about it. And upper motor neuron is also, depending on where we are talking about, it can be quite long, although it's often shorter. So you need to think about, for example, if we are talking about, let's say, the arm, okay? So the lower motor neuron could be that they have got carpal tunnel syndrome and they've got median nerve impingement. That's quite distal, isn't it? Or it could be all the way up in the brachial plexus, which is a bit further up, but they're both lower motor neurons, right? So that's the kind of thing that I'm trying to get at. And offer one or more reasonable causes of the lesion, all right? So this can be injury, space-occupying lesion, infectious causes, vascular causes, vasculitis, anything and everything, all right? You need to go through your surgical sieve, put them together and come to a sensible conclusion with a number of different causes. What you don't need to do is to come up with 5 different differentials of complex and hardly ever seen neurological syndromes, okay? That is not expected of you. Even trained, experienced neurologists do not do this, okay? You don't even need to pinpoint exactly where the neurological lesion is, okay? By exactly, what I mean is, specifically which part of the brain, for example. You need to be able to tell which side, you need to be able to tell general areas like the lobes, the angles, stuff like that, key areas. You need to know your key areas. So the patient is going to need a whole host of investigations, regardless of what they may be having, right? In front of you, the patient may have had a stroke or trauma, whatever. They may be post-surgical, whatever it may be. They are going to need a whole host of investigations in order to reach the diagnosis, right? What you are going to do is offer these in your presentation when you are presenting to the examiners. This shows that you are a sound clinician and you're not just, stabbing in the dark, okay? You are not just guessing things, you're not just making things up, because that is dangerous and that is what you need to avoid being. Your examiners, your consultants want a safe registrar who is logical and who is able to piece information together and reach a reasonable management plan which is safe, okay? They don't want a trained neurologist who is going to come up with 12 different differentials of syndromes that even they have never heard of, only to be a dangerous clinician, okay? They don't want that, all right? So let's give you an example. What am I trying to get at with all of this? Okay, so I thought the best way to do this is by giving you an example. So let's think about this. So a middle-aged patient, man or woman, comes in, okay, and you are the registrar. You are in your PACES exam, okay, and you are faced with this patient who has a left-sided facial droop, as well as unilateral sensory neural hearing loss and left-sided homonymous hemianopia, okay? Take a few seconds and think about what is going on here. Just take a few seconds. Okay, so now that you've had a few moments, I hope that you have a good idea of where the lesion might be, because this should give things away to a certain extent. However, the key thing is that you don't have to be able to diagnose exactly what kind of lesion the patient has had, has had in the past, okay? What you do need to be able to notice is that they may have a scar on the affected side, which may be a surgical scar, most likely. So what could this mean then? It could mean that they had surgical removal of a previous space-occupying lesion. This could be an aneurysm, a tumor, or maybe an abscess. Who knows? They're all space-occupying lesions, right? Or maybe they had an acute vascular incident like an extradural or intracranial hemorrhage. Although this presentation, it's probably less likely, but who knows? Or stroke, okay? The site, in terms of the site, you do need to be able to kind of localize where the affected site is, okay? So this would be the cerebellopontine angle, right? And this would suggest that the patient probably had a previous acoustic neuroma which has been excised. So this presentation is suggestive of that. And the scar on the affected side would be in keeping with an excised previous acoustic neuroma, okay? But what you need to be able to get to is that you need to present your findings in this way, okay? After you've presented your findings in this way, what you would do is then say, my differentials would be these kind of in this order, rather than, saying some fancy syndrome first. Don't do that. You're just shooting yourself in the foot. You need to say these kind of things, and probably even this. This makes you sound like you are being a reasonable clinician. If you can, always try and provide the location of the lesion in your presentation in the neurological exam. The location of the lesion is important, so do try and provide this. And after providing your differentials, you would then move on to your management. Okay, so your management would obviously involve the diagnosis first of all, because you don't know, right? So you would always say, regardless of what examination you're doing, neurological, cardiac, respiratory, abdominal, anything, you would always start off by saying that you would take a full history of the patient, okay, first, and also move on to performing the rest of the neurological examination. So that's what you would start off by saying, and then you would proceed to the rest. And the management would include things like MRI, okay, to diagnose and look at the lesion. MDT, multidisciplinary team. This would involve the physio, speech and language assessments, ophthalmology, driving restrictions. So driving restrictions are important, especially for UK. You need to always think about DVLA. Anyway, so I hope that you can see what I'm trying to get at, okay? You don't need to come across as specialists. You don't need to come across as knowing your neurological syndromes, all of them by heart. You don't need to do any of that. What you do need to be able to be safe. You do need to be able to piece information together. You do need to be reasonable and provide a lesion and its site and its possible causes. I hope you found this valuable. I'm going to leave you with that. As always, my course is available as well, which I would recommend you check out. I will see you in the next video, guys.